Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone, and welcome all to our second Young Leader Forum Symposium for year 2021. Today, our symposium topic will be around thyroid disease and titled Thyroid Made Easy. We extend our grateful thanks to Servier for their unrestricted support for this educational activity. Before we start our presentations today, we would like to have some housekeeping announcement. First of all, this recording and this meeting is live streamed in EDS YouTube channel, and also it will be available on demand webinar section in EDS Institute website. During the presentations, we encourage all the audience to write their questions in a Q&A box, and hopefully we will handle all of them at the end of the first three presentations. For any support, you could have a live chat support through WhatsApp, through WhatsApp with the provided number. Also, would like to mention that this activity is accredited by Dubai Health Authority up to 1.5 CME hours. Before also we start, I would like to remind everyone that EDS is your society, and we encourage everyone to participate. And for those who are interested to participate in a future event, please do contact mci.com and they will try to contact you with us. So starting with the first presentation, titled Approach to Thyroid Disease in Pregnancy, and our speaker is Dr. Jamila Al-Dhuhuri. Dr. Jamila is consultant internal medicine and endocrinologist in Ambulatory Healthcare Service Abu Dhabi, Zafarana Screening and Diagnostic Center. She has extensive experience where she worked as a head of department in Abu Dhabi Police Medical Service, running diabetes and endocrine service, and also worked in Sheikh Khalifa Medical City Diabetes Center, as well as Obesity Bariatric Department in KMC. She is a graduate of Harvard Program for Research and Statistics and had involved in several research around pre-diabetes, diabetes, and hyperlipidemia. She had certificate of American Board of Medical Quality and Master in Healthcare Management from Royal College of Surgeons, Ireland. Dr. Jamila, welcome, and thanks for your involvement with us. And please, the screen is yours, and share your presentation.
Thank you, Dr. Raya, for the kind introduction. It's my pleasure to be here today as a presenter in the Young Leaders Forum. I'll start my screen sharing. In the coming half an hour, I'm going to discuss my objectives, which are approach to thyroid disease and pregnancy, the interpretation of thyroid function test in pregnancy, iodine nutrition, thyroid autoantibodies and pregnancy complication, hypothyroidism in pregnancy, overt subclinical isolated free hypothyroxemia, and thyrotoxicosis in pregnancy and Graves' disease. Finally, touching some the points in the screening of thyroid disease in pregnancy. Thyroid disease is a very common problem in pregnancy. It has a profound impact on thyroid gland and its function. An accurate assessment of maternal, fetal, and thyroid function during pregnancy remains difficult. Interpretation of laboratory testing differs from the non-pregnant patient, and universally screening thyroid function in all women either before or during pregnancy demonstrate a mixed conclusion. By anatomy, everyone is aware like thyroid gland is a butterfly-shaped gland in the neck. It's under the control of pituitary by the hormone of TSH. Here, a magnification of the thyroid follicle showing the process of the thyroid hormone synthesis, starting with the iodine trapping, organification, coupling, and storage of the thyroxine until it gets signals from the TSH to be released into the bloodstream. Physiology of a pregnancy is associated with increase in renal iodine excretion, increase in thyroxine binding proteins, increase in thyroid hormone production, and increase in stimulatory effects of HCG. Thyroid function test of healthy pregnant women differs from those of healthy non-pregnant, and the reference range for the TSH and free T4 varies significantly in different populations. Here is a diagram that shows whatever I have mentioned in the changes of physiology in the pregnancy. The most important changes is the drop of the THS in the first trimester and the decrease in the free T4 amount throughout the pregnancy. There is another cartoon showing the concept of decreasing the free T4 amounts wherever you find the increased thyroid binding globulin in pregnancy, leading to decreased free T4 compared to the pre-pregnancy status. During pregnancy, TSH are lower because of cross-reactivity of alpha subunit of human HCG, and changes in serum binding protein levels influence the measurement of a free T4 assay that relies on the estimates rather than the direct measurement, resulting in inaccurate reported values. So every physician should know the limitations of the locally available methods in his practice. TSH level should be considered the most accurate indicator of gestational thyroid status. There is a downward shift of TSH reference ranges occurs during pregnancy, and this reduction in both the lower and the upper limit of maternal TSH. It's by 0.5 to 1 approximately relative to the typical non-pregnant TSH reference ranges, and the largest decrease happens in the first trimester. If you are aware, this is the table showing the ATA guidelines in 2011, which was having the upper limits of the TSH 2.5 in the first trimester, 3 in the second and third. At that time, the American Endocrine Society was sharing the same cutoffs. However, the European Thyroid Association was more relaxed in the third trimester, it was 3.5. So although there is a downward TSH shift in the different population, the reduction varies with the racial and ethnic group. And initial studies of pregnant women in US and Europe led to recommendation of TSH upper reference ranges of 2.5 in the first trimester and 0.3 and 3 in the second and third. However, more recent studies in pregnant women in Asia, India, and the Netherlands have demonstrated only modest reduction in upper reference limit. A study of 4,800 pregnant women in China recently showed a downward shift in TSH occurred in the first trimester, but it was minimal, from 5.3 to 4.3. This is a table showing the different populations and the amount of reduction. Whenever possible, population-based trimester-specific reference ranges for serum TSH should be defined through assessment of local population data representative of a healthcare provider's practice, and this determination should only include pregnant women with no known thyroid diseases, optimal iodine intact, and those who are antibody negative. If these are not possible and for any reason pregnancy-specific TSH ranges are not available, an upper reference limit of 4 may be used. Here is a study from UAE done by Dr. Khalil and his colleagues that were looking for the serum TSH and T4 ranges among pregnant women from UAE. And their conclusion was that TSH trimester-specific reference ranges in UAE pregnant women were higher than those recommended by ATA in 2011, but are in keeping with the latest guidelines published in 2017. What about iodine nutrition? Because of increased thyroid hormone production in pregnancy, increased renal iodine excretion, and fetal iodine requirement is increased, dietary iodine requirements are higher in pregnancy. And those who have optimal iodine supplements and requirements has been fulfilled have no difficulty adapting to increased demand for thyroid hormone during gestation. However, if there is deficiency, it will lead to impaired maternal and fetal thyroid hormone, and in turn, low thyroid hormone values would lead to increased pituitary TSH production, resulting in maternal and fetal goiter. In areas of severe iodine deficiency, there has been noted cases of thyroid nodules, cases of pregnancy loss, stillbirth, increased prenatal and infant mortality, and cretinism has been found in areas of severe iodine deficiency. Approximately of 250 microgram iodine daily is required, and universal salt iodization is the most cost-effective way of delivering iodine to improving maternal and infant health. There is no need to initiate any iodine supplementation on those who are receiving treatment with LT4 or anti-thyroid medication. Thyroid autoantibodies and pregnancy complication Regarding that, the antibodies are present in around 20 to 17% of unselected pregnant women, and the prevalence varies with the ethnicity. In U.S. population, they found that most frequently found in Caucasian and Asian women, but least in African American. The vast majority of studies done on the antibodies are mainly looking at the TPO antibody measurement. So that ATA 2017 recommends assessment of TPO antibodies when testing the presence of thyroid autoimmunity. In women with thyroid autoimmunity, hypothyroidism happens because of stress of pregnancy. There is the ability of the thyroid to augment hormone production is being compromised. In 1994, Glanier and his colleagues had a prospective study where they found that 20% develop a serum TSH more than 4 during gestation despite normal pre-pregnancy TSH values. And 12 years later, Negro and his colleagues also demonstrated the same finding that TSH level increased as the gestation progressed. Endocrine disorders has been recognized as a risk factor for spontaneous or sporadic pregnancy loss. Patients with poorly controlled diabetes, for example, has 50% risk of pregnancy loss. Those with thyroid has similar figures, and Stangro and Green, his colleagues, first demonstrated association between pregnancy loss and thyroid antibodies. And they found that patients who were positive for thyroid antibodies demonstrated a twofold increase in the risk of a pregnancy loss. Since that time, numerous other studies have examined the association between maternal thyroid antibody status and pregnancy loss risk, showing similar findings. And although a clear association has been demonstrated between thyroid antibodies and spontaneous pregnancy loss, it doesn't prove causality until now, and the underlying mechanism for such association remains unclear. Again, in the study of Negro, it has a randomized interventional study, as I mentioned, to LT4 in euthyroid patients who were TPO antibody positive, and the researchers reported significantly decreased rate of pregnancy loss in the LT4 treated group compared to the others. But the limitation of this study was that mean estimated gestational age at starting LT4 was 10 weeks, but all 8 losses of untreated group has occurred before 11 weeks. So this findings raises uncertainty as the impact of the intervention upon the endpoint. So euthyroid pregnant women who are TPO or thyroglobulin antibody positive should have measurement of TSH concentration performed at the time of pregnancy confirmation and every 4 weeks through mid-pregnancy. Summary of my first part of presentation: that thyroid function tests of healthy pregnant women differ from those of non-pregnant. TSH should be compared with the local population-specific trimester ranges. Women with adequate iodine intake before or during pregnancy have no difficulty adapting to increased demand of thyroid hormone during gestation. ATA 2017 recommended TPO antibody as the gold standard antibodies for the autoimmunity. Hypothyroidism is generally defined as the presence of elevated TSH and decreased free T4 during gestation, with both concentration outside the trimester and population-specific ranges. Most common causes: iodine insufficiency or autoimmune thyroid disease. Subclinical, on the other hand, subclinical hypothyroidism is increased TSH concentration that is not synonymous with the decreased free T4. Isolated hypothyroxemia is low free T4 concentration detected despite normal TSH concentration. Adverse outcomes associated with overt hypothyroidism include the premature birth, low birth weight, pregnancy loss, lower offspring IQ, and different studies have found different percentage. In above village has been 60% fetal loss, and in Long and his colleagues found 22% risk of gestational hypertension. And finally, Allen has showed an increased risk of fetal death, similar to the other previous studies. Numerous prospective and case control studies confirm the determinantal effect of overt hypothyroidism on both pregnancy and fetal health. Recent retrospective study of more than 1,000 pregnant women on chronic LT4 replacement showed that the risk of pregnancy loss increased proportionally to the degree of TSH elevation, with no increased risk associated with the TSH normalization. Although there is no prospective randomized investigation on LT4 investigation because such studies would be unethical to complete, available data confirm that treatment of overt hypothyroidism is recommended during pregnancy. Subclinical hypothyroidism as well has been linked to other adverse effects affecting the pregnancy outcomes like the pregnancy loss, miscarriages, prenatal outcome with a premature delivery, hypertensive disorder, and adverse neurocognitive effects. And available evidence appears to show an association between hypothyroxemia and cognitive development in the offspring with uncertain effects on prematurity and low birth weight. However, no studies exist that LT4 administration has been shown to ameliorate such harm effects. The famous CATS trial conducted on 499 patients were identified to find low T4 concentration, and half of them has been randomized to treatment with LT4. The intervention, however, failed to demonstrate any improvement in neurocognitive outcome in the offspring after 3 years of age. LT4 treatment, a dose of 50 microgram could be typically required for effective treatment of subclinically hypothyroidism. And according to the ATA 2017, and under the recommendation 28 and the recommendation number 29, it states as the follows: pregnant women with TSH concentration more than 2.5 should be evaluated for the antibody status, and subclinical hypothyroidism should be approached in 3 different scenarios. The first scenario is that therapy is recommended for TPO positive patients with the TSH greater than pregnancy specific ranges, and TPO antibody negative women with TSH greater than 10. However, it is treatment should be considered in TPO antibody positive women with TSH more than 2.5, but below the upper limit of pregnancy specific ranges. And for those who are TPO negative with the TSH concentration greater than the pregnancy specific ranges, but below 10, it is not recommended in the third scenario for TPO antibody negative women with the normal TSH. This is the diagram that summarizes whatever I have mentioned among the 3 scenarios, showing the positive antibody patients versus the TPO negative antibody patients. Isolated hypothyroxemia, it has been studies showing decreased affecting the pregnancy in terms of decreasing the psychomotor test scores in the offspring, reduction of IQ among offsprings as well. There are other studies showed the findings of small head circumference, autism, and this has been among different studies that has been done worldwide. And very few studies have investigated isolated hypothyroxemia and adverse pregnancy outcome, expecting birth weight and premature delivery. Available data suggest an association with higher birth weight and higher risk of premature delivery. So how it should be managed? Although several studies have been reported adverse outcome in children born to mothers with isolated hypothyroxemia, there is no interventional data have yet been published to demonstrate a benefit effect of LT4 therapy. There is one observational study has been demonstrating delayed infant neurodevelopment in women with persistent hypothyroxemia. However, when FT4 concentration increased during pregnancy, infant development was not compromised. At present, there are 2 randomized prospective intervention trials in which women with low T4 were treated at different trimesters, and both investigations failed to show any beneficial effect on cognitive development. So the recommendation was that isolated hypothyroxemia should not be routinely treated in pregnancy. How to monitor women with overt subclinical hypothyroidism or those at risk for hypothyroidism, either positive antibodies or post-hemithyroidectomy, or those who has been treated with radioactive iodine. They should be monitored with the serum TSH measurement approximately every 4 weeks until gestation, and at least once near 30 weeks of gestation. And hypothyroid patients receiving the LT4, they should independently increase their dose by 20 to 30%. And once they are aware that they are pregnant as well, they need to notify their healthcare provider. Another way of making it simple for the patients is just to advise them to take 2 additional tablets weekly of their current total dose. Summary of the second part: the treatment of overt hypothyroidism during pregnancy is recommended. Women with the TSH concentration exceeding 2.5 should be evaluated for antibody status. There are mixed conclusions for the subclinical hypothyroidism. and the scenarios varies based on the levels and the antibody status. And patients with hypothyroidism receiving the LT4, they should increase their dose by 20 to 30% and notify their caregiver. The thyrotoxicosis in pregnancy is defined as the hyperfunction of the gland, and it is the most common cause in pregnancy is the Graves' disease, accounting to 0.4 to 1% of women having it before pregnancy, and 0.2% develops it during pregnancy. And there are other frequent causes and least common. However, in our presentation today, I'll go through the Graves' disease and gestational transient thyrotoxicosis, which happens mainly in the first half of pregnancy. Serum TSH may decrease in the first trimester of normal pregnancy, and peak HCG level usually occurs in the first trimester. Serum TSH below 0.1, in some cases even undetectable, and 5% by week 11. Any subnormal TSH value should be evaluated in conjunction with the serum T4. So the biochemical diagnosis of earth hypothyroidism is by presence of suppressed or undetectable TSH and inappropriately elevated serum total T4 or free T4. Gestational transient thyrotoxicosis, there is elevated T4, free T4 and suppressed TSH. Associated with hyperemesis gravidarum, severe nausea, vomiting, and more than 5% weight loss with dehydration, ketonuria. Other conditions associated with HCG-induced thyrotoxicosis include multiple gestation, high datiform mold, or choriocarcinoma. This is a table summarizing the difference between the GTT and the Graves' disease and how to differentiate between them. Both have the same symptoms of palpitation, anxiety, tremor, and heat intolerance. And the GTT, there is no prior history of thyroid disease. It's a self-limited mild disorder. Symptoms of emesis occurs, no stigmata of Graves' disease, and serum HCG is higher. There is positive TRAP in Graves and high total T3. Ultrasound has not shown beneficial in differentiating between the two conditions. And in pregnancy, the scanning and radioiodine uptake determination or radionuclide scintigraphy are not recommended. The management of GTT is supportive therapy, mainly management of dehydration, hospitalization if needed. Antithyroid treatment, antithyroid drugs are not recommended. Beta blockers could be considered. Management of patients with hyperthyroidism important because poor control of thyrotoxicosis may lead to pregnancy loss, pregnancy-induced hypertension, prematurity, low birth weight, stillbirth, or thyroid stone. Women with the Graves' disease should be counseled to postpone any getting pregnant plan until they are rendered euthyroid. And stable euthyroid state is defined by 2 sets of thyroid function tests within the reference range at least 1 month apart with no change in the treatment in between. And a pregnant lady or hypothyroid patient who desires future pregnancy may be offered definitive therapy with ablative or surgery or medical therapy, which are, I spent some time in this table showing that every option is associated with the benefits and disadvantage. The antithyroid drug is effective with treatment and it often induces gradual remission of autoimmunity. It's easily discontinued or modified. It can be easy to take and relatively inexpensive. However, there are mild side effects, adverse effects of some allergies. It could be happen in 5 to 8%. And there is a severe side effects of neutropenia, but it's very rare. It can happen in 0.2%. There are birth defects associated with the use of this medicine during pregnancy, and relapse and withdrawal is likely to happen in 50 to 70%. The radioactive iodine treatment is easy oral administration. It reduces the goiter size. However, the future relapse of hyperthyroidism is very rare. Compared to the drawbacks is that sometimes repeat therapy might be needed. Antibody titer might go high, and this would affect negatively those with the orbitopathy, and it could lead to fetal adverse effects. Lifelong therapy with levothyroxine might be needed. Thyroidectomy, definitive therapy, and the patient would be stable euthyroid state achieved with the replacement at that time. Post-surgery, there'll be gradual remission of autoimmunity. The goiter will disappear. And the disadvantage is, again, the lifelong lead of levothyroxine or thyroxine treatment and surgical complication. Antithyroid medication, if diagnosed with the woman and the patient appears to be in remission, the option is to withdraw the antithyroid medication and perform repeated thyroid function testing during the first trimester. And if it is really needed during the first trimester, PTU is preferred over the others because of risk of severe birth defects are lower with this one. Cessation of medication has to be recommended early in gestation before the major teratogenic period, and following cessation, maternal thyroid function testing TSH and free T4, a clinical examination should be performed every 1 to 2 weeks. If remains clinically and biochemically euthyroid, then test interval may be extended to 2 to 4 weeks during the second and third trimester. The aim of treatment one has to remember is always to keep the T4 and free T4 or the total T4 at or just above the pregnancy specific upper limit of normal with the possible smallest dose of antithyroid disease, medication. Over treatment should be avoided because of possibility of inducing fetal goiter and fetal hypothyroidism. Maternal total T4 or free T4 and TSH should be measured approximately every 2 to 4 weeks following initiation of therapy and every 4 to 6 weeks after achieving the target values. The summary of this part is that women with the TSH less than the reference range in first trimester should go thorough evaluation, including measurement of free or total T4, TSH receptor antibodies, and total T3, but they should not undergo radionuclide scintigraphy or radioiodine uptake determination. Management of normal maternal thyroid test results caused by gestational transient thyrotoxicosis depend on supportive therapy. Before attempting pregnancy, women with thyrotoxicosis should become euthyroid with other the treatment options mentioned in the previous table. For newly pregnant women with Graves' disease and who is euthyroid, low dose or stopping medication would be the best approach. And if required, PTU should be over the MMR. Screening in pregnancy, there is insufficient evidence to recommend for or against universal screening for abnormal TSH concentration, with the exception for those who are planning assisted pregnancies or known to be antibody positive. Universal screening to detect a low free T4 concentration in pregnant women is not recommended. All pregnant women should be verbally screened at the initial prenatal visit for any history of thyroid dysfunction or prior or current use of LT4 or antithyroid medication. Those people who are listed in the current slide are those who would require daily screening, those who are more than 30 years of age, non-type 1 diabetes or other autoimmune disease, multiple prior pregnancies, family history of autoimmune thyroid disease, morbid obesity, has been having amiodarone or lithium or recent radiologic contrast administration, who are living in areas where there are severe or moderate iodine deficiency, who have history of hypothyroidism or hyperthyroidism and on active treatment, or those who have antibody positive or presently having goiter. So universal screening for thyroid disease and pregnancy is not recommended based on the American College of Gynecology practice compared to the one which I mentioned in the ATA 2017 guidelines. So the conclusion was that there is insufficient evidence to recommend for or against universal screening for abnormal TSH concentration preconception, with the exception for those who are planning assisted reproduction or those who have TPO positivity. With this, I think I'm reaching near end of my slide. Thank you for your attention.
Thank you very much, Dr. Jamila, for your extensive review around this rich topic. And now I would like, before introducing the second speaker, to encourage all the audience to place their question in the Q&A box. And please specify the speaker for whom you are directing the question. Now, our second lecture is titled The Light in the Midst of the Storm, a case presentation that will be conducted by Dr. Azza Abdulaziz bin Hussein. Dr. Azza is consultant endocrinologist in Dubai Diabetes Center. She is board certified and fellow of Royal College of Physicians, and she has extensive experience in endocrine and thyroid ultrasound. And also she is certified by the American College of Endocrinology for neck ultrasound in 2014. And since then, she has performed more than 2,000 procedures. She is very active member in teaching both under and postgraduate students, and achieved a master's degree in leadership in health profession education. Welcome, Dr. Azza. The screen is yours. Please share your slides.
So, Assalamu alaikum, everyone. Is my screen shared?
Yes.
Okay. Hi, Assalamu alaikum, everyone. Thank you, Raya, for the nice introduction. I'm delighted to be here today with you to share one of the challenging cases I came across in the past. And I hope that this presentation will be interactive. I have some polling question also. So I want the audience to be awake with me. So this is a story of a 40-year-old female with no past medical history presented to the accident emergency with complaint of shortness of breath, palpitation, abdominal distension, and lower limb swelling. On examination, her temperature was 38.1, a pulse rate of 224, and a blood pressure of 93/48. So she was hemodynamically unstable. The cardiovascular examination, she had irregular pulse with raised JVP and an S3 gallop with bilateral lower limb edema. Chest examination showed decreased air entry bilaterally with bilateral crackles, and the abdominal examination showed distended abdomen, which is tender, and liver palpable 4 centimeter below costal margin. So the emergency physician have sent some initial workup to rule any source of infection, and the set of order he ordered a full blood count with a WBC count of 9.7 and an absolute neutrophil of 7.5, which was normal, a C-reactive protein, which is normal, a procalcitonin, which showed low risk, and negative culture. For the biochemistry, her urea electrolyte were normal, apart from liver function tests, which showed raise in the bilirubin of 3.6, alkaline phosphatase of 348, and gamma GT of 48. Her coagulation profile showed mildly raised INR, normal cardiac enzyme, and a raised cardiac ProMP of more than 3,000. So he did an ECG, which showed atrial fibrillation, poor R wave progression, and diffuse T wave inversion. This clinical feature suggests heart failure. So she presented with lower limb edema, raised JVP, bilateral crackles, and high cardiac ProMP. She had irregular pulse with an ECG showing atrial fibrillation. Although her cardiac enzymes were normal, she had on ECG diffuse T wave inversion. So they wanted to exclude an acute cardiac insult. So the emergency physician thought, could this be something related to an acute ischemic attack or myocarditis or something else? So he referred her to the cardiologist. The cardiologist did a bedside echo. The window was poor, and although he could visualize the ejection fraction, which was 20%. An ultrasound abdomen showed congested liver, ascites with pleural effusion. These findings with an impaired liver function test could be most likely related to her cardiac insult. So the diagnosis of the cardiologist was decompensated heart failure with reduced ejection fraction, atrial fibrillation with fast ventricular response, bilateral pleural effusion, transaminitis. They admitted her to the CCU, and they started her on anti-farrier medication and management of atrial fibrillation. which include digoxin, bisoprolol, enoxaparin, ramipril, Lasix, and spironolactone. So keep in mind you have a lady who presented with unstable hemodynamic. She came with atrial fibrillation and in heart failure. Few days later, the cardiology repeated an echo. Her ejection fraction mildly improved from 20 to 35 to 40%. However, she had moderately dilated right and left atria with moderate mitral regurg and tricuspid regurg and mild pulmonary hypertension with a pulmonary artery pressure of 40 millimeter mercury. Further testing showed that she is in thyrotoxicosis. So this lady presented with atrial fibrillation and thyrotoxicosis. I'm aware that you know the relation between atrial fibrillation and thyrotoxicosis. However, are you aware of the other cardiac manifestation that can present with hyperthyroidism? To explore your knowledge, I'll be starting with you my first polling questions. So I hope my audience are ready. So the first polling question, how often do we see atrial fibrillation in association with thyroid disease? Less than 5%, 5 to 20%, 20 to 40%, 40 to 50%. Your polling starts now. You have 15 seconds. Okay, so 5 to 20, so mostly they answered, 54% answered 5 to 20%. I'll be giving you the answer later during my presentation. My second polling question, the following are risk factors for atrial fibrillation in patients with thyroid disease. You can choose more than one answer. Older age, female gender, heart failure, comorbidity, and presence of valvular cardiac disease. I can remind you that you can choose more than one answer. Your polling question starts now. You have 15 seconds. Okay. I have 50% for everything. So let's go to our next our third polling question. How common is pulmonary hypertension and thyrotoxicosis? 30 to 40%, 40 to 50%, 50 to 60%, 60 to 70%. Okay, interesting. Let's go to our last polling question in this set. The following are risk factors for pulmonary hypertension and Graves' disease. Older age group, women more than men, presence of high TSH, and hypertension. Okay, mainly the answer went for presence of high TSH receptor and 52% went for women more than men. So Let's evaluate this. The thyroid hormone affects the heart in two ways: either increase in heart rate, cardiac contractility, systolic and mean pulmonary artery pressure, cardiac output, and decrease in myocardial oxygen consumption, or reduction in systemic vascular resistance and diastolic pressure. Combination of this both causes multiple cardiac decompensation. For the atrial fibrillation, the incidence is 5 to 15, and the risk factors are male sex, elderly, more than 60, in association with coronary heart disease, heart failure, and valvular heart disease. We have other risk factors, which include obesity, chronic kidney disease, proteinuria, raised T4 concentration, and raised transaminase concentration. Now, this is a diagram that correlates the TSH and the incidence of new onset of atrial fibrillation. The lower the TSH level, the higher the incidence. So if I'm having a patient with atrial fibrillation and hyperthyroidism, what's the long-term run? So if the patient has no structural heart disease, then 55 to 75% will revert to sinus rhythm within 3 to 6 months of adequate treatment of the thyrotoxic state. How about pulmonary hypertension? Pulmonary hypertension is defined by a pulmonary artery pressure of 25 millimeter mercury at rest and more than 30 millimeter mercury during exercise. In hyperthyroid state, the average is twice normal value. So you can have a high value of 30 to 50. To remind you, Our Lady had a value of 40 millimeter mercury. She had mild pulmonary hypertension. The risk factor for pulmonary artery hypertension is autoimmunity, young age, and female gender. So what's the relation between pulmonary hypertension and thyroid disease? Overall, 20% of patients with pulmonary hypertension have thyroid disease. Some studies showed that 65% of those with Graves' disease had pulmonary hypertension. On the other hand, 22% of patients with pulmonary hypertension had hypothyroidism. Almost all reverted to normal with treatment of hyperthyroidism. From this, a recommendation came out that all patients with pulmonary hypertension should be screened for hyperthyroidism, and all patients with hyperthyroidism and shortness of breath should be screened for pulmonary artery hypertension. Now, back to our case. Our cardiologist realized that this patient is in thyrotoxicosis. So he consulted endocrine. The endocrinologist attended the patient, reviewed the history and examination. On review of history, there was no significant symptom of hyperthyroid apart from occasional palpitation, weight loss of 5 kg, and the family history of mother with thyroid illness. On examination, she was irritable, anxious, febrile, no eye signs, no tremor, and had grade 1 goiter. The endocrinologist ordered further set of blood tests and imaging study. The thyroid antibody showed that the anti-TSH receptor was positive. So you're having a case with hyperthyroidism and positive thyroid antibody. So the cause of her hyperthyroidism is Graves' disease. This is her imaging study. It shows the right and the left lobe. It shows heterogeneous thyroid gland with increased vascularity on Doppler study. This picture resembles something we know as thyroid inferno, which is that the thyroid is on fire. My last polling question is, what do you think this patient has? Severe thyrotoxicosis or thyroid storm? You can start the polling question. You have 15 seconds to answer. We have 60% for thyroid storm and 40% for severe thyrotoxicosis. To answer this, we will revert to the BW score, which is a score that endocrinologists use to know the likelihood of thyroid storm. There are elements there, and to remind you with our case, she had a temperature of 38.2, which gives her 10 points. She was mildly agitated, that is an additional 10 points. She had moderate abdominal pain, that is an additional 10 points. Her heart rate was more than 140, which gives her 25 points. She was in atrial fibrillation, this is an additional 10 points. She had moderate basal crackles, and that's an additional 10 points. She did not have any precipitating factor. If we sum the score, her score is 75. So this scale identifies the risk or likelihood of thyroid storm. If we have a score of more than 45, this is highly suggestive of thyroid storm. If our score is 25 to 44, then this is suggestive of impending storm, which is severe thyrotoxicosis. Below 25, unlikely that she has thyroid storm. Our endocrinologist diagnosed her as thyroid storm. She was clinically mildly thyrotoxic, however, biochemically severely thyrotoxic, complicated with heart failure and fast atrial fibrillation. The endocrinologist managed her with carbimazole, hydrocortisone, local Lugol solution, and cholestyramine. Our management was based on our local protocol. So we have the anti-thyroid medication and we have the option of propylthyroxine versus carbimazole. Our protocol suggested carbimazole in thyroid storm. Then we have the anti-adrenergic drugs. Propranolol in a dose of 60 to 80 milligram every 4 to 6 hours. However, you need to be aware that and cautious when using it in reactive airway disease, peripheral vascular disease. It's better to use a cardioselective beta blocker. To remind you, our case, our cardiologist put her on bisoprolol. So in patients with acute heart failure, you either can go with IV ismoprolol or oral bisoprolol. The other drugs, we have iodine preparation, which is Lugol solution, 10 drops 3 times daily for 5 days. But keep in mind, when you're giving Lugol solution, you can give it at least, you should delay it at least 1 hour from starting your anti-thyroid medication. You have the steroids and the bile acid sequestrant. It is essential not to forget the supportive measure. So, adequate hydration. However, keep in mind if you're having a patient with heart failure, you shouldn't overload them. Antipyretic, GI prophylaxis, DVT prophylaxis. In case of atrial fibrillation, you need to give anticoagulation based on CHAD score and review your DVT prophylaxis. And please consult the cardiologist for this. Word of caution. You need to notify your patients about adverse reaction of carbimazole and propylthyroxine. You also need to counsel them about when they need to repeat and monitor the FBC and LFT. So a full blood count will be needed if the patient is in fever, infection, or sore throat. In case they had some yellow discoloration, itching, or any symptoms suggestive of hepatitis, they need to repeat an LFT. If your patient is smoking, you need to advise them strongly to stop smoking. And that is because we want to avoid developing risk of graves of pneumopathy. In females in reproductive age, inform them that carbamazole is teratogenic, and they need to use oral contraceptive method with their gynecologist. In case they got pregnant, they have to attend the clinic, and for which the carbamazole will be switched to propylthyroxine. When treating this state, we have targets. Other than normalizing the thyroid function test, do not forget the resting heart rate. It should be 60 to 70. Now, what happened to our case during her follow-up visit? On the 9th of June, she was seen by a cardiologist who repeated an echo. Her ejection fraction was normalized to 55 to 60%. She still had the right atrial dilatation, mild to moderate MR, and grade 3 diastolic dysfunction. They decided to stop her ACE and Lasix. They down titrated her bisoprolol from 5 milligram to 2.5, but they continued her anticoagulation. And they ordered for her Holter monitor, another set of echo in 1 month time. On 7th of July, the cardiology reviewed her, and her Holter and echo was normal. Her Concor was reduced from 2.5 to 1.25 milligram for 1 week and then stopped, and her anticoagulation was stopped. On the same day, she had an endocrine consult. She complained of preorbital edema. She was clinically hypothyroid. Her blood test, her TSH was 1.3, and her free T4 was low, 4.3. So she had hypothyroidism, and her carbamazole was reduced. When reviewing the trend of her thyroid function test, at baseline, her T4 was 90.8, and her TSH was less than 0.05. After 1 week, her T4 normalized, and within 12 to 13 weeks, she became hypothyroid. She was seen by the endocrinologist, and her carbamazole was reduced. I want now to conclude my slides with the latest guidelines in management of thyroid storm. In 2016, the Japan Thyroid Association and the Endocrine Society guideline came for recommendation on the management of thyroid storm. So you can use antithyroid, either methimazole or propylthyroxine, and they recommended IV methimazole in severely ill patients who have altered level of consciousness or impaired gastrointestinal tract function. Remember to give Lugol solution 1 hour after antithyroid drugs. Steroid should be given regardless of the origin of thyroid storm. So you have a total dose of 300 milligram per day of hydrocortisone versus 8 milligram per day of dexamethasone. Do not forget aggressive cooling with antipyretic and cooling blanket in cases of thyroid storm with high fever. If there is any source of infection, then this should be treated. This is an important point. Beta-selective adrenergic receptor, either IV ismolol or oral bisoprolol, should be selected as first choice of treatment for tachycardia and thyroid storm. Although non-selective beta-adrenergic receptor propranolol is not contraindicated, it is not recommended for treatment of tachycardia and thyroid storm. In atrial fibrillation, you can give digitalis. However, if your vital signs are unstable and you ruled out a left atrial thrombus, then you might need a cardioversion. After cardioversion, and to maintain sinus rhythm, you might also need to add class 1A or 1C antiarrhythmic. If your atrial fibrillation persists, then you need to start an anticoagulation based on CHAD 2 score. Don't forget the GI prophylaxis. All thyroid storm cases which present with shock, DIC, and multi-organ failure should be admitted to the ICU. Definitive treatment for Graves' disease, either with radioactive iodine treatment or thyroidectomy, should be considered to prevent any recurrent thyroid storm. Now, my take-home message. Cardiac involvement is common in patients with thyrotoxicosis. All patients with thyrotoxicosis and shortness of breath should be evaluated for pulmonary artery hypertension. And all patients with pulmonary hypertension should be screened for thyroid disease. Thyroid storm should be expected in any patient with high-grade fever, fast tachycardia, or arrhythmia. Prompt management of thyroid storm in a multidisciplinary approach saves life. Supportive management is essential as the anti-thyroid medication, the beta blocker, the glucose solution, steroid. These are my references. And in our case, the light is that there is reversibility of cardiac manifestation with proper treatment of thyrotoxicosis. And thank you.
Thank you very much, Dr. Azza, for this interesting case. Now we will move for the third lecture, titled Skills in Reading Thyroid Ultrasound. The speaker is Dr. Mariam Saeed, who is consultant physician and specialist endocrinologist in Mediclinic Dubai Mall. She is adjunct assistant professor of medicine in Mohammed bin Rashid University of Medicine and Health Sciences. And her main area of interest is diabetes, thyroid disorders, and obesity management. She is certified by the American Association of Clinical Endocrinologists in neck ultrasound and FNA. Dr. Mariam, welcome, and thanks in taking part of this symposium. Screen is yours. Please share your slides.
Thank you, Dr. Raya. So I've been asked to present on the basics of neck ultrasonography. And now the background of the audience, I'm aware, is quite varied. There could be family medicine physicians, some of you endocrinologists, internal medicine physicians. So I'm going to try to include something for everyone in here, just being cautious of the different backgrounds. So to start with, I have no disclosures. The learning objectives of this talk would be to recognize the indications for an ultrasound and the advantages of a point-of-care sonography, to understand the basics of thyroid and neck anatomy on an ultrasound, the structure of a comprehensive ultrasound report. We're going to go through this in detail. Ultrasound reporting terminology, and to identify pertinent positive and negative signs on the thyroid ultrasound, as well to interpret the thyroid ultrasound images following existing guidelines. So starting with the indications for a thyroid ultrasound. Now, I know a lot of family medicine physicians could be watching this, and we may all be guilty of ordering lots and lots of thyroid ultrasounds or any scan to start with. First of all, it doesn't have any radiation. It's easy to order, it's cheap, it's available. And when you find a patient who's coming to you with a neck swelling, or even just sometimes hypothyroidism, sometimes there's thyroid hormone dysfunction, the first thing that a lot of doctors would do would be to order thyroid function tests and they also add in that ultrasound. Now, you really have to think. Sometimes ordering an ultrasound when you're suspecting a thyroiditis could be beneficial. For example, say in a pregnant woman with Graves' disease, she can't have any other scan. It's going to take time to get the antibodies. You really want to see whether that gland is vascular. It makes perfect sense. In follow-up of thyroid cancer patients, of course, you need to have a preoperative scan, a post-operative scan, things like parathyroid disease, cervical lymphadenopathy, but the mainstay by far is thyroid nodules and multinodular goiters. This is the main reason we do ultrasound scans, and we'll go through this and focus on the nodules for now. So how can thyroid nodules present? Either the patient is going to come to you with a complaint, you may do a physical exam in your clinic and discover a nodule. It may be found by accident through another imaging. For example, sometimes there are patients who are having a workup for a TIA or a stroke, and they have a carotid duplex done, which just happens to show a nodule in the thyroid, or CT scans for the chest, or in someone with thyroid hormone dysfunction, maybe hyperthyroidism, and you just want to look at the vascularity or whether there's any functioning nodule there that showed after scintigraphy. So how accurate are we when we're talking about being in clinic and examining our patients who are complaining of a swelling or may not be complaining of swelling, and you're doing a routine exam? How accurate are we in our clinical exam? Now, you may recall the days when it was quite common for family medicine physicians and endocrinologists as well to use an ophthalmoscope to look at the back of the retina in diabetic patients. Over time, we discovered that wasn't very accurate. And now we have cameras which do this for us. We have artificial intelligence. We're linked to computer systems that an ophthalmologist at tertiary referral centers who can have a proper look at the back of the eye. So we really, it's only in limited places, probably with limited resources, that they would continue that. And I'd say it's probably the same with thyroid ultrasound and thyroid nodules. So in several epidemiological studies that have been done since the 60s and 70s up to now, it's probably palpable in only up to 5% of patients. But when you do an ultrasound, it's anything between 20 to 60% of patients could have nodules. It's more common in women, it's more common in the elderly. So once you've ordered an ultrasound, obviously, radiology department would be the first stop. So radiologists would get would do all the ultrasounds, but some endocrinologists would do their own ultrasounds. So this would be called point of care sonography. So the moment they step into your clinic, you're having a quick scan, you're having a look to see what's going on. Now, the benefit of this was first discovered by trauma surgeons. It's used extensively in emergency care for other areas, obviously not for the thyroid, but point of care sonography is definitely a very beneficial tool. It can help you answer a specific clinical question. It can be, it's efficient. And sometimes having that real-time dynamic image rather than images recorded and interpreted later on allows you to see things and correlate it with the patient's history at that moment. Things like, for example, artifacts like comet tail artifact on ultrasound. Sometimes that's only clear when you move the probe up and down, and you can appreciate that yourself if you're doing the scan. So I would say it's probably endocrinologist doing an ultrasound versus a radiologist doing an ultrasound. It's probably like going on a holiday yourself or looking at somebody else's holiday photos. So I'd rather go on the holiday myself. So advantages of point of care ultrasound, it's problem focused, as we said, and several studies have shown as well the operator performance is variable. We have to keep this in mind. It's better with more experienced sonographers, and it's also different based on the practitioner specialty. So for example, surgeons who were doing their own ultrasounds documenting neck lymph nodes before patients went for surgery were more efficient and accurate at detecting the lymph nodes compared to radiologists in one study that was done. And this is because they are focused on the anatomy. They know they're going to go in there, they're going to operate. They look at the areas that are important to them. rather than a radiologist who may be doing a very general scan. And this is just an unpublished study done with my colleague, Dr. Badur at Dubai Hospital. And we actually looked at the accuracy of ultrasound looking for a suspected parathyroid adenoma in the endocrinology department compared to the radiology department. 71% of the cases of parathyroid adenoma were found when it was done by endocrinology versus only 52% by radiology. So to start with the neck ultrasound basics now. So thyroid and neck anatomy. So the thyroid, as my colleagues have mentioned before, is a butterfly-shaped gland. It roughly lies where probably just above where a necktie would be in men. So it's surrounded by blood vessels. So the common carotid artery either way, the jugular veins, and it has the esophagus just behind it, probably on the left side, and the trachea just in the middle at the back. So when you position your patient for a neck ultrasound, it's very important to know the different types of views you could get. So there's a transverse view, which is when you hold the probe horizontally on the neck, just as the picture on the left. And there is a longitudinal or sagittal view. And this is when you hold the probe vertically on the patient's neck. These gives you different views. And we'll explain a little bit later what the significance of this would be. So if any of you are taking screenshots of this, this lecture will be available online later on. But if there's any screenshot you're going to take, I'd recommend this one and the one after, because literally it summarizes the whole presentation. So a structure of a comprehensive thyroid ultrasound report. This is really important because we read reports most of the time, whether we do the ultrasounds or not. Not everyone here does a thyroid ultrasound, but all of us read reports given to us, done by someone else. You really need to, the same way you look at journal articles and you would be critical of the journal article, you need to do the same with reports. Is this report complete? Is it telling me the whole story? Is there anything missing? Do I need to go and speak to the radiologist? Do I need to repeat the scan? And what should I do? So you need to make sure all these components are there when you're doing an thyroid ultrasound or reading a report. So the clinical indication, this is so important. Why was this ultrasound ordered? So you should know, is it a female, male patient? How old are they? Do they have a history, a family history of thyroid cancer? Did they have thyroidectomy? Do they have autoimmune disease? And what's the current complaint? Then you move on to the gland as a whole. So you have to describe it, and things that we would cover would be the size in 3 dimensions, the parenchyma, the vascularity of the gland. Once you describe the gland as a whole, you'd move on to what's in the gland, which would be the nodules. And again, the characteristics of the nodules, the number, the size, the shape, the margins, the echogenicity or echogenic foci or calcifications. Now, all of these criteria we've taken kind of from different guidelines. So there would be the ATA, the American Thyroid Association guidelines, the ACE guidelines from 2016, and as well as ACR TIRADS from the American College of Radiology. So we've gone through the indication, we've looked at the gland, we've looked at the nodules within the gland and described them in detail. We move on to lymph nodes in the neck, the size of the lymph nodes, the number, where they're located, the way they look. Are they calcified? Are they vascular? Are they invading anything? Do they look suspicious? After that, you'd look at anything else in the neck. So you could comment on the parathyroid if it's there, if it's not visible, on the any structures such as a thyroglossal cyst, retroesternal extension, or tracheal compression. At the end, the most important thing by far would be your interpretation and recommendation. So you have to classify these nodules that you saw. Does it look high risk? Is it low risk? When should the scan be repeated? Do you recommend surgery? Do you recommend an FNA? Are you going to do an FNA? So it's really important to add that last bit to your report. So to start with, we're going to move through the whole structure of a thyroid ultrasound report. To start with the thyroid gland as a whole. So this is the way it's going to look like on an ultrasound. ultrasound. So the thyroid gland is, if you can see my pointer there it is. It's like an upside down U shape. This would be the trachea in the middle. That would be the common carotid artery. Usually you'd find the esophagus somewhere either lower down on the left on most times, and sometimes it could be visible on the right. So the right thyroid lobe is here. Just above here where my pointer is, this would be where the skin is at the top, the anterior part of the neck. This would be the posterior. And this is the isthmus, the bridge connecting the two. So starting with the thyroid gland, you'd go to measure the size, starting with the right thyroid lobe. And you could see the screen is split into two. We're looking here on the transverse view. This is when you put your probe horizontally, as I showed. And this is when you put it longitudinally. So it's the same thing. This is the right thyroid lobe of the same thyroid. You're getting here a longitudinal measurement, and you're getting here an anteroposterior, or the depth of it, and you're getting the width here, which is the transverse view. So you're getting two readings here, one reading here. Because the thyroid is a three-dimensional structure, you can get the volume estimated as well in milliliters. There's a formula for that, but the machine will give it to you as well. So we started with the right, we move on to the left, we do the same thing, and then we would measure the isthmus, and the isthmus usually is only measured in AP diameter, just in the middle. So the way you'd report this is just a rough example. You have to say the thyroid gland was normal. Is it symmetrical? Is it enlarged? Is it asymmetrical? What was the measurement and volume of the right, the left, the isthmus? And you have to always have this in your report. What is the order of measurements? So all measurements are in the order of length, depth, and width, unless otherwise specified. I mean, sometimes people have reports where they start with the width, then the depth, then the length, and it makes a difference what you're talking about, because when you're going to compare the size of this nodule in the future, you really need to know which was which. So moving on, after the size of the gland, you'd look at the parenchyma. So the parenchyma is the tissue, the way it looks. And you have on the left a homogeneous gland, which is smooth. And you could see a heterogeneous gland. You'd find this in cases of thyroiditis, and it doesn't have a uniform color. So if you'd compare these two, this is just basically plain, smooth. The other one is just colorful. And why is this relevant to know the difference between an inflamed looking gland with parenchyma that's heterogeneous is because of pseudonodules. Now, frequently we get referrals from radiologists, family medicine physicians, describing multiple tiny cysts that they found on the ultrasound scanner. Obviously, it's very concerning for the patient, for the doctor who sees this. But in patients with features of thyroiditis, sometimes you literally can't see what's going on. There could be a very heterogeneous looking parenchyma that basically looks like it's nodules, but they're not nodules. So how can you differentiate the two? It's by checking the three-dimensional measurement of the nodule. So you're gonna put the probe in horizontally, so transverse view. You're gonna put it vertically, which is longitudinal view. And you won't find it in one view compared to the other. It's going to disappear because it's not really there. The other thing is, if you repeat the scan in a while, it may disappear. And in reports, you really find radiologists don't even give them a measurement or size. They just say they're multiple and they're everywhere. Okay, so pseudonodules are literally fake nodules. When you report on parenchyma, you have to say whether it's homogeneous, heterogeneous, and whether there are nodules or cysts bilaterally. Moving on to vascularity of the gland. So you could have overall normal vascularity, increased, or as my colleague had shown you before as well, an inferno, such as in Graves' disease. So overall increased vascularity, you have to mention that in your report. Moving on to the main bread and butter of thyroid sonography, thyroid nodules. So what is a nodule? Nodule is a discrete lesion in the thyroid gland that radiologically looks distinct from the surrounding tissue. There are many characteristics, but mainly there's 5 or 6 of them that you really need to know of. The characteristics of nodules. You need to describe all of these to really be able to estimate the risk of malignancy. So you need to mention the number of nodules, where they're located, their size in 3 dimensions, not 2. The composition, is it solid? Is it cystic? echogenicity, their color, their shape, their margins. Are there any calcifications, and the vascularity? So to localize them, as we mentioned, anterior is up there, posterior is down, medial in the middle, lateral on the side. So a nodule that would be located here would probably be described as anterolateral in the left thyroid lobe, okay? And when you have multiple nodules, describe the ones that have the most malignant features, not the largest one. The largest one could be completely benign. So the size, nodules are three-dimensional. I can't stress this enough. The volume can be calculated by this formula. It's pi/6 by all the dimensions. You have to compare the size to the previous scan. As per ACE and ATA as well, nodule enlargement is defined as more than 20% increase in at least 2 dimensions, or more than 50% increase in volume. When we say this nodule increase, be very careful that you're talking about increase in the solid component. If it's an increase in a cystic or water component, you have to mention that, because sometimes you have cysts that just grow, so you don't go and biopsy them because they grow. Be aware of interoperator variability. This isn't engineering. There's going to be some differences in a few millimeters every time you measure it yourself or someone else measures it as well. So don't let your patients panic about a few millimeters increase or decrease compared to the previous. So once you report them, you have to mention it in your report, the number, the size, any change compared to previous. The composition of the nodules now, a solid nodule you could see there on the left, partially cystic, it looks like it's septated in the middle, the dark areas would be water, and a spongiform nodule usually is benign. Literally, it looks like a sponge. You could see multiple areas of fluid mixed with solid tissue. Cystic nodule would be completely black. So it would be look like this watery area with nothing else in it, no solid at all. The echogenicity, by far, this is one of the most predictive markers of malignancy in thyroid nodules. So if it's hypoechoic, it is a sign of that it could be malignant. Now, this is very hypoechoic and this is hypoechoic. Isoechoic means the color is the same as the tissue. So it really is the color compared to the tissue around it. So if it's darker, it's hypoechoic. If it's the same, it's iso. If it's whiter or brighter, it's hyperechoic. The nodule shape. So on transverse view only. So when you have the probe here horizontally only on this view, you look at how tall it is compared to the width. If it's taller than wide, again, this is a malignancy risk. So you have to report on that. If it isn't, you have to say it's not taller than wide. You have to mention that in your report. The margins, these have nice, clear margins, and sometimes the margins aren't very clear. You're not very sure where it's ending. Sometimes you can have halos. It's like a ring, a dark ring. That's a good sign. If you don't have a halo, again, that's a malignancy risk. Echogenic foci, these are calcifications, basically. You could have tiny calcifications, white spots like this one here, or you could have eggshell just at the rim, which is interrupted. Sometimes you have something called comet tail artifact. So it looks like a calcification. It's a white dot, but then it has, when you move the probe, it has a trail behind it, like a comet basically in the sky. So that's really a benign sign. So it's very important for you to get a hang of this and focus on these features to be able to tell the difference. Vascularity of the nodule can be graded as 1 to 4. Most commonly, we find nodules with grade 2 or 3 vascularity. Grade 2 would have a rim. They would have peripheral vascularity. So just there's blood flow all around the nodule. With grade 3, it's all around and inside as well. It's more vascular. So you have to report it, include all of these features of the nodules in your report. So moving on to lymph nodes. So with the lymph nodes, these are mandatory to check on when you're looking at an ultrasound, because having malignant looking lymph nodes, again, is a risk factor that's very relevant for if you're looking for thyroid malignancy. So normal lymph nodes, the most important thing is to know the way a normal lymph node looks. It's oval. It has this thing called a fatty hilum in the middle. This is it on the image. It's oval, and there's this fatty hilum in the middle. Usually the blood flows through here. If you switch on the Doppler ultrasound, you're going to see blood flow here. It does not have calcifications. It does not look like a nodule. You have to measure the size, but again, it's normal. There are 300 lymph nodes in the human neck. It's normal to find a few of them in the neck. You have to mention where you found those lymph nodes. So there are 6 levels. This was done by the American Academy of Otolaryngology. So level 1, just here under the chin. There's obviously on 2 sides as well, left and right. 2 just below the ear. You have level 3 here, below 4. Level 6 is usually behind the thyroid, but once someone has had a thyroidectomy, frequently you get malignant lymph nodes there. And level 5 at the back, that's the supraclavicular node. So you have to mention where those lymph nodes are. Again, these are from ATA. These are the concerning features of lymph node. And you can see this one here, this image I had taken of one of my patients. Her lymph node literally looks like a thyroid nodule. It does not have a fatty hilum. It's just all tissue. It has calcifications. It has this chaotic blood flow from all over. It's not going through the hilum in the middle. So this is definitely a malignant nodule. So that's the way you report on it. You mentioned the location, the size, and whether it has a hilum and whether there are calcifications. Moving on to extrathyroidal structures, I'm not going to go through this in detail. You mentioned anything on parathyroid, on the carotid, on any invasion, on any retrosternal extension. The most important thing, how you're going to interpret all of this. So how are you going to interpret it? So the objective is you want to classify the risk of malignancy. Now you have different guidelines that can help you with this. You have ATA from 2015. It has 5 categories from benign to high suspicion. ACE has only 3, low risk, intermediate, or high risk. And ACR TIRADS has 5 as well, similar to the ATA. So you need to group them. You need to do that, you need to have all those details mentioned on the characteristics of the nodule to be able to group them. Otherwise, there's no point of having the scan because you wouldn't know what to plan next. This is taken from the ATA guidelines. It's just a visual guide showing what the features are for a high suspicion nodule, an intermediate, a low suspicion, very low, and that's the chances of it being malignant just mentioned there. This is just my own drawing of the same thing, just simplified here. So you have the high risk, you have suspicious lymph node. If it's taller than wide, it has interrupted calcification, it has punctate lesions, it's hypoechoic, it's irregular margins, and it's solid. And you can see based on ATA as well, there are recommendations there. So you would biopsy this if it was more than 1 centimeter. But for example, in a low suspicion nodule, it has to be more than 1.5. Again, the follow-up would be different as well. So the time frame for follow-up for these more benign lesion is longer. And these are spongiform nodules or partially cystic nodules. The benign nodule would be completely cystic. Now, very important here is there are some nodules that are actually unclassifiable. They don't fit into any of these categories. Mostly those are nodules that are isoechoic or hyperechoic, but they have extra suspicious features, such as taller than wide or some calcifications. It's estimated that among all the guidelines, ATA, ACE, and TIRADS, around 2.5 to 5% of nodules could be unclassifiable. And when they looked at the malignancy rate in them, up to 38% were actually malignant. So that's a bit of a controversy. Common pitfalls to summarize in thyroid ultrasound reporting, keep an eye for it, no clinical indication, only 2 dimensions of nodules described, missing nodule characteristics, nobody mentions the calcification, the margins, no info on the gland, there's interoperator variability, no lymph node mapping, and most importantly, no risk stratification of nodules or recommendation on follow-up. So when you're looking at these images, you're not just simply describing what you see, you're describing what you see to assess the possible risk. And these are just some few examples of actual ultrasound reports that I've seen that did not contain all the information. So a very large nodule here of 3 centimeters, and at the end, it just says there's non-specific thyroiditis. It's not giving this any importance at all. Another one, which is all over the place. So it says it's heterogeneous. And then it says 2 lymph nodes, which look inflammatory, but they're not. This was actually it. It was a very malignant looking lymph node described as an inflammatory lymph node. So be very careful with the kinds of reports you're getting. have opened the image if you can and have a look at it. This was, again, the same node scanned later on by another radiologist with a more comprehensive report. Another one here, not mentioning all the characteristics, but at the end concluding that it's Thyroid 4 for an FNA. How did we get the score of Thyroid 4? I don't know, because you have to, with thyroids, you calculate a score for every feature that you see. When those features are not mentioned, you can't make assumptions that they don't exist. So in this study of around 1,300 individual patients in Canada, study of thyroid nodules on ultrasound scans and the reports, they found that only 13% of reports described a minimum of 4 out of these 6 nodule characteristics that are necessary to estimate the risk for malignancy. So basically, only in the majority of those cases, 85% at least, you couldn't conclude anything from those reports. You couldn't quantify a risk score. So to summarize, thyroid nodules are common. They can be present in about half of the population if they had a scan. Point of care sonography is useful. There's unique terminology you should know if you're looking at ultrasound reports. Pattern recognition requires experience. Beware of the pseudonodules. They're very common in thyroiditis. My recommendations would be for you to obtain a reference manual. There are 2 good books here that I would recommend. They're mentioned at the end as well in the references. Create a template on your electronic health record to fill the ultrasound report with headings. Look at images if in doubt. Discuss with your radiologist. Select one malignancy risk estimation, such as ACR thyroids or ATA, and follow it, but you need to be familiar with the others. There are some apps that can help you with this that are in development. You need to practice. And last but not least, you have to please correlate clinically. Obviously, the radiologist can't do that, but you can as a clinician. Thank you.
Thank you very much, Dr. Mariam, for this elegant presentation. Now, I would like to invite all the speakers for the Q&A session. So I will start with you, Dr. Jamila. Just can you re-highlight briefly the thyroxine replacement in patient or initiation in patient with a pregnant lady with subclinical hypothyroidism, if they are TBO negative or positive, and the cutoff TSH?
Yes, sure, Dr. Araya. Do you want me to share the screen of the slide again? It would be easier.
If you wish, that's fine.
I'll just go to the slide. I know that one it would really need further discussion, and it has a lot of studies based on this gray area. Actually, the time limit and time frame did not allow me to continue with this further discussion and details, because I need to cover the other parts of it. But I have this slide.
I think the main question was around the TSH of 10 and TBO negative.
I'll do this. Anyway, the slideshow, I need to end this slideshow.
Okay, since to give you time to find the slide, I could move to the second question for Dr. Azza. Meanwhile, you could figure out the slide, Jamila. So, Dr. Azza, you just mentioned regarding the pulmonary hypertension and thyrotoxicosis. So is this associated to thyrotoxic state itself, or it is related to the autoimmunity? So is it specific only for a Graves' disease?
So it's basically with autoimmunity. However, pulmonary hypertension has the other role of the systemic resistance and other things, but mainly it's the autoimmunity.
Okay, so we may not find this in other form of thyrotoxicosis then?
Based on my literature review, it's basically in Hashimoto hypothyroid, which was 22% versus mainly Graves' disease, which is 65%.
Excellent. Okay, so back to you, Dr. Jamila.
My slide is clear now, Dr. Araya?
Yeah.
So if we look at the recommendation it's mainly I discussed the ATA 2017 recommendation. I know there are other recommendations, the ACOG, American College of Gynecologists. There are other societies have been going through it, but I found that the extensive recommendation has been done by the ATA 2017 was based on the presence of the antibodies and negative antibodies, and at the same time the different concentrations of the TPO and of the TSH. If we said like there are three different scenarios. The first scenario whether to treat, and the second scenario just to consider treatment, and the last scenario is no treatment. So for those who are the question was for those who are more than
TSH and antibodies negative.
So if the antibodies are negative and TSH is in the upper reference range of the pregnancy, but less than 10, at that time you consider the treatment. But if the TSH is more than 10, you treat.
Okay. Thank you, Dr. Jamila. Dr. Mariam, there was a question in regard to how often do you follow thyroid goiter with the ultrasound in case of benign or malignant features? Both.
Okay.
I think this is very broad question.
It's a very broad question, but again, it's different if it's malignant or benign, obviously. But if it's malignant, obviously the patient is going to go for surgery, they're going to go for treatment. But in case of benign nodules, so it depends on the features of the nodule. So if it was, say, if you're following the ATA guidelines, if it had high risk features, you would obviously need to do an FNA if it fit the criteria, and the recommendation is to repeat another FNA within 6 to 12 months of the first one. If you have 2 negative FNAs, then you can repeat it in close to 18 months. But what they would recommend is every time you follow, if it's the same size, if it hasn't changed and you've already cleared the malignancy, you may stretch the gap between those measurements. So eventually in someone you're not really concerned about, they have benign features, you could stretch it up to 3 to 5 years.
Excellent. Back to you, Dr. Jamila. Question regarding a young lady who had just recent miscarriage, and they managed to check her TSH, which was 6. How do you approach such case?
I believe such cases are frequently encountered during the clinical day, and it could be referred to you by gynae or by family medicine. And since Dr. Maria mentioned, like the audience are variant, so we'll just discuss the approach. This lady is a young and fertile lady presented with post-miscarriage. We know like the thyroid hypothyroidism, subclinical hypothyroidism would lead to the miscarriages, and on top of it, presence of antibodies would be a factor that has been studied to cause like miscarriages. So my first approach is having high TSH, which is beyond the reference ranges of the pregnancies. Then I need to do for her the antibody, check the antibody status. If the antibodies are positive at that time, it makes the situation and the scenario high and treatment side towards not to treat. And especially this lady would be considering after this emotional distress of miscarriage to go on pregnancy soon. So this would help her as well to just minimize the risk of future miscarriages, as well as it will promote and improve her chances of getting pregnancy.
Thank you. Another question for you, Dr. Jamila. So regarding the antithyroid drug, the preferred antithyroid drug during first and second trimester, is it BTU and third trimester carbimazole?
Actually,
or how is it?
We know like there is teratogenic effects of antithyroid drug, and according to the later studies and the recent ones, they are just trying to warn us regarding the teratogenicity of the antithyroid drug. Before we used to think like even PTU is more safer than the MMI, but it's found like it even carries the risk. So it's the best option is just to render the patient euthyroid before pregnancy. If this is not being achieved, or the patient just recently developed this in a pregnancy, then the first trimester preferred medicine is PTU compared to the MMI because the risk of teratogenicity is higher in the carbimazole group compared to the PTU. Until the first half of the pregnancy, then you can switch. Keeping in mind, like the switching period would have some of the instability in the condition. However, we need to also remember like the percentage of or the ratio of the switching is 1 to 20. So this, like for example, if you want to use 20 of 100, so this is 1 to 20.
Excellent. Thank you very much. Dr. Azza, next question for you. Regarding the etiology of thyrotoxicosis induced heart failure, is it due to high demand or dilated cardiomyopathy or other pathophysiological mechanisms?
That's a nice question. Due to the time, I did not discuss the other manifestation of thyrotoxicosis and heart disease. So we have the cardiomyopathy, we have angina-like symptom. So basically, it is, if you're having tachycardia, it will lead to atrial fibrillation and then increase in demand, and then you'll go into heart failure. And cases with thyrotoxicosis and heart failure, approximately it is in 6 to 8%. And if there is any, like, if the patient has no structural abnormalities, then with treatment of the thyrotoxic state, all the changes, especially the dilated cardiomyopathy, will revert back to normal.
Okay.
So they do promote dilated cardiomyopathy. In our case, she had dilated cardiomyopathy with tricuspid regurg and pulmonary hypertension.
Excellent. Another question for you, Dr. Azza. You just mentioned regarding the preferred beta blocker to be used in case of heart failure and thyrotoxicosis. So why not to use propranolol, since it have the additional effect with high doses and conversion of T4 to T3?
Okay, so I mentioned that in 2016 guideline that cardioselective is preferred. So the oral bisoprolol or IV ismoprolol, especially with tachycardia in thyroid storm. So I can revert back to, there was a wide nation study done in Japan, and they said that in thyroid, they realized that in thyroid storm, there is already reduced peripheral conversion of T4 to T3. So if I want to give the propranolol, there's no additional benefit over the cardioselective. You got me, yeah?
Yeah. Dr. Mariam, there is a question in regard to ultrasound use in diagnosing dysthyroidism without a structural anomaly. I don't understand what do they mean exactly.
I think dysthyroidism, no structural abnormality probably means a functional abnormality. So thyroid hormone dysfunction, for example, hyperthyroidism or hypothyroidism. Now, the ATA does not have mention it specifically in their guidelines to have an ultrasound in cases of hypothyroidism unless there was a reason for it. So unless there was a goiter, unless you palpated something, unless there was a family history or another risk factor, you know, radiation exposure as a child, there has to be a risk factor for you to consider having that ultrasound. Now, just as part of practice, a lot of endocrinologists would like to have a baseline ultrasound done on all patients with hypothyroidism, just because we know that in the event that a patient with hypothyroidism did develop a thyroid malignancy, they are more likely to get lymphoma. So they are actually more likely to get thyroid malignancies and develop those goiters. So a baseline ultrasound may be done just as a screening process, but this is not mandatory. And the focus should be on someone with who you're really highly suspecting of having structural disease.
So, another question for you, Dr. Mariam. You highlighted or you went through some of the scoring system, ultrasound risk scoring system for malignancy. So which one of these are best in terms of diagnostic performance to select which nodule to go for in and perform FNA?
Sure. The three that I focused on, which are the most popular, are the American Thyroid Association 2015, ACE with the Italian Endocrine Society, that's 2016, and ACR TIRADS 2017. They're all similar. None is superior to the other. That's why you're open to choose which one suits you best. However, there were some studies, several studies looking at this. The sensitivity of the ACE seems to be the highest, but the specificity in the with the ATA and the Thyroid seems to be more. ATA seems to be better, not just in general in specificity, but in nodules that are large, above 2 centimeter. So if you have a nodule that's above 2 centimeter, ATA is more specific than Thyroids, but if it's below, they're the same. So there's all kinds of differences, but overall, the diagnostic accuracy would be similar.
Excellent. For you now, Dr. Jamila, there is a question in regard to any role for a block and replace in treatment of a Graves' disease during a pregnancy.
Excellent question, Dr. Raya. Actually, I would like to cover it in my presentation, but for the sake of time, again, as I mentioned earlier, block and replacement therapy used to be applied in the past, but lately it was found like it's not the optimal way. The block and replacement therapy in the hypothyroidism would have another like reversal impact. If, for example, if we are treating the patients for hyperthyroidism and we are using the anti-thyroid drug for her, it's known like it will cross the placenta. And on top of that, if we add the thyroxine would stay less crossing the placenta compared to anti-thyroid drug. In that case, we would require more doses of anti-thyroid drug, which would lead to fetal hypothyroidism, and then we would have different impacts. The only indication for having the block and replace therapy, as per the literature reviewed done for the presentation, it was shown that in the cases of fetal isolated hyperthyroidism, where you would need at that time anti-thyroid drug for the fetus, and this could happen if the patient, if there is a trap crossing the placenta, patient has past history of ablation therapy. So in that case, you would need the anti-thyroid drug for the baby and the thyroxine for the mother. This is the only scenario that is applicable for the block and replacement therapy.
Excellent. Dr. Azza, there is a question for you in regard to the use of BTU in thyroid storm. In your case, you have used carbimazole, though BTU may be preferable for the conversion as well again. So did you use it in your case because of raised LFT baseline, or there is another reason?
Excellent question. So in our case, as per our local protocol and where I used to stay, where I used to work in Dubai hospital, so we prefer carbimazole over PTU. And because the patient has had deranged liver enzyme, and we know that PTU can cause some advanced liver damage. But I want to tell you again that as per the wide nation study that was done in Japan, they realized that in thyroid storm status already there is reduction in the peripheral conversion of T4 to T3. So it did not show any superiority of PTU over carbimazole.
Excellent. Yeah. Excellent. Dr. Mariam, there is a question, I think, in regard to how they could get or do hands-on course on thyroid ultrasound, if you could direct them.
Okay, actually, what I had done myself, so I was in Dubai hospital previously. Over there, the endocrinology department, the endocrinologist would have an ultrasound, a thyroid ultrasound clinic. Now I'm aware and in my current practice as well, I do have an ultrasound with me. So I do point of care ultrasound. However, I'm aware this isn't the case in most places. So in a lot of places, you'd have to refer to your radiologist or colleague elsewhere. There was a course done by the American Association of Clinical Endocrinology, ACE, previously, called ECNO, and the certification called ECNO. Now, they have discontinued this since late 2019. or early 2020. It does not exist anymore. So it used to be a course, hands-on course in the United States, and they used to run it a few other places as well, where you would do theory and then you would do a hands-on course, and you have to study for an exam. Once you do the exam, then you have to submit cases with the report, and they would critique that. It used to have an expiry date of 10 years once you do the course, but now they've given permanent certificates to everyone because they've just stopped doing this course. I'm not aware if they will create a new one in the United States. I know there's another one done by the radiologist. Now, hopefully that is something that maybe EDS could look into, of setting up a hands-on course for anyone who's interested.
Very good suggestion. Excellent. I think we have only one question more we can handle due to the time limit. So, Dr. Azza, is there any steroid preference in treating patient with thyroid storm? I mean, the selection of which kind of steroid, or between, for example, hydrocortisone and dexamethasone here in the question?
So either can do. There's no preference of one over the other.
Excellent. Thank you very much. Thank you for all the speakers for your contribution and for your elegant presentations. And hopefully we could see you again in future events. Now we will move to our next presentation that will be sponsored by Surveyor, who are providing the unsupported, the unlimited support for this educational activity. And it will be about glycoside MR safety and effectiveness from landmark study to real world settings. And again, our speaker is Dr. Mariam Saeed, who have been already presented before. Dr. Mariam, you can share your slides.
Sure, thank you. So I'm just gonna share my slides here. So this is just a 15-minute talk. So on a real-world study that was just completed for glycoside MR, these are my disclosures. And to start with, let's look at the advancement of therapies for type 2 diabetes, or diabetes in general, over the past 15 years, roughly. So if you look at all those medications here that were introduced, whether they were combination drugs, whether they were standalone drugs of different categories, DPP-4 inhibitors, GLP-1 agonists, new insulins, and SGLT2 inhibitors, we've had a revolution really in the available choices of diabetes therapy over the past few years. However, what's sad, really, you could say, is that there actually hasn't been much change in the average HbA1c level of our patients, specifically those who are achieving, the percentage of patients achieving an HbA1c below 7%. Now, this data is from the United States, but if we look at our own data here in the UAE, this was a study that I participated in, done by my colleague, Dr. Elamin Abdelkader in Dubai Hospital, which looked at glycemic control in the UAE. It involved 26,000 patients from primary healthcare and tertiary healthcare centers. Around 3/4 were UAE nationals, looking at their average glucose control through their HbA1c levels. And you could see just in the gray there on the bar chart, that's the percentage over the 5 years of the study, from 2012 up to 2016, the percentage of patients from those 26,000 who were achieving an HbA1c below 7%. So it improved slightly, but it really is not perfect. So it's the same case for us as the rest of the world. We're not seeing really much change with HbA1c levels on average. Now, you may be familiar with the UK-PDS study, which showed that there's an average of 37% risk reduction for microvascular complications for every 1% of HbA1c reduction. So this would obviously affect patients in terms of their retinopathy rates, their nephropathy rates. And this is significant. In all the studies that were replicated, all the landmark trials, the microvascular disease improved with better glycemic control. Now, there is a debate and controversy about macrovascular disease, but in general, microvascular disease improved. If you look at specific cohorts of patients who were young, who did not have, who were not at high risk for cardiac disease to begin with, who started treatment early, even in those cases, there was benefit for macrovascular disease. So glucose control is important. Now with the all the new selection of drugs that we have, we're focusing on cardiovascular risk, which obviously is important. We're focusing on renal disease. But at the end of the day, glucose control is essential. This is what we do when we treat diabetes. We improve glycemic control. Improved glycemic control is important. If you look at the European Society of Cardiology guidelines from 2019, they mention this, that glucose control to a near normal of, which is below, defined as below 7%, decreases microvascular complications, and tight control, especially in younger individuals, leads to reduction in CV outcomes if you look at it in the long term over a 20-year time scale. And however, with elderly patients, you have to be less rigorous. Again, here on the right, in a recent cohort study, you could see that glycemic, out of all the factors here that would increase risk for a myocardial infarction or a stroke, you could see that glycated hemoglobin levels here by far the most important. So glycemic control is a priority. The guidelines currently recommend GLP-1 agonists in people with high cardiovascular risk, especially for atherosclerotic disease, as second line after metformin, or SGLT2 if there's predominantly heart failure. Next, you find a whole selection of drugs there, including DPP-4 agonists, antagonists, and including insulins, things like pioglitazone and sulfonylureas as well. So the greatest absolute risk reduction, as per the ADA, comes from improving glycemic control. So if we look at all the landmark studies done on type 2 diabetes management over the century, really, the revolution really occurred over the past 20 to 15 years. This is when the most medications have been launched. But look at our bread and butter here. Look at our insulin, metformin, sulfonylureas, way back since the 1940s and 1950s, still in use today. So what is the value when you have all these landmark trials? What is the value of having real world data? So the difference is when you have a randomized controlled trial, you're really checking, can it work? But when you have real world data, does it work? You're actually putting it into action. And these days with COVID and with the vaccination launches for COVID and the trials that were done and immediate launch into the real world, we can see what difference there is between a trial and application in the real world. So the time frame between injections, side effects in patients, the efficacy over the long term. We're seeing this live these days with the vaccination launches around the globe. And the same actually applies to any drug that's out there. If you monitor this over in the long term in the actual population that you're treating, you may actually find differences from what was suggested in the randomized controlled trials. So if we actually took a patient database today, such as that from the Scottish Care Database or the Royal College of General Practitioners, and we tried to enter those patients in for all these landmark trials, you could see the percentage of patients who actually qualify if they go through the rigid inclusion and exclusion criteria. So only 11% in Accord, 35% in Advanced, 3.5% Proactive, 9.2 Record, and it goes on and on. So real world data does have its role. It does have its limitations, but it does have its role when we look at the efficacy of the drugs we use. So moving on to the real world study of gliclazide MR versus sitagliptin. Now, the interesting concept behind launching or creating such a study was because these are two very commonly prescribed medications, not just very commonly prescribed as a second-line agent after metformin. Okay, so metformin is first line, second choice. Majority of patients back when this study was started were being given either a DPP-4 inhibitor or a sulfonylurea. So and there were no real direct comparisons with gliclazide. There were many studies done looking at other sulfonylureas, but not at gliclazide MR specifically. So the primary outcome they looked at here, this was a study done on roughly around 2,000 patients. And they looked at the time to reach an HbA1c level less than 7%. And the secondary outcomes, that was the primary outcome. The secondary outcome was to get it less than 6.5% or reduce your hemoglobin A1c from baseline by 1%. They also assessed two things called durability and persistence. What they mean by durability was how long the patient remained on that drug before they needed to change or add another agent. And persistence was how long they stayed on that medication before it was discontinued, okay? Because the theory was that people don't stay on sulfonylurea for long. Once they start on it, eventually other agents are added or it loses efficacy and they need to stop it and move on. So this was to test how durable or persistent it was against the DPP-4 inhibitor. Again, to look at hypoglycemia events, obviously sulfonylureas had a notorious reputation, especially with the older agents such as glyburide with hypoglycemic events. So the study design was actually over 9 years. They started this in early January 2010, and they observed this group of people, this group of patients of around close to 2,000 patients over 9 years. It ended in October 2019. The age was over 18 and adults who were on metformin, whose HbA1c was at least more than 7% in the 6 months prior to the study start. And they excluded, obviously, patients with secondary diabetes or type 1 diabetes. Baseline characteristics was similar between the two groups, on sitagliptin and on gliclazide. Slightly more percentage of men in the study, average age is around 63. They had a high level of HbA1c of around 8.5 in both groups. They were obese with a BMI of more than 30 on average, which is quite high. They had diabetes roughly for around 4 years. So they were new, relatively new, but not that newly diagnosed. And you could see there as well how many of them had known kidney disease or heart disease. And many of them as well were on anticoagulant therapy and statins and other lipid-lowering therapy. So the primary outcome you could see here on the right, gliclazide actually dropped the HbA1c level, the primary outcome, quite fast, literally within the first 3 months to reach that target of below 7%. So 35% more likely patients who are on gliclazide to reach the target HbA1c. In the secondary outcome, again, 51% of patients on gliclazide were more likely to reach the target HbA1c of less than 6.5. If we look at the hypoglycemic events, there were definitely more hypoglycemic events in the gliclazide group as expected. However, this wasn't statistically significant. Per 1,000 patients, there was around 4.7 events with gliclazide, 2.6 with sitagliptin. The number of severe events, which is quite significant here, was 4 with gliclazide and 1 with sitagliptin. Majority of events were non-severe, but there were severe events as well. So to summarize this real-world study that was recently published in 2020, so real-world studies complement randomized controlled trials. There's extensive experience in using sulfonylureas, more than 60 years history. It definitely has good efficacy and durability. It's an effective drug. It does have hypoglycemia. However, compared to older sulfonylurea agents, it's less. We need to invest in a holistic therapy for patients when we have limited resources. These medications are affordable, they're available, they're effective, they're oral, and they are part of they are a choice that we still have. So to conclude, we're fortunate really, especially here in the UAE, to have a wide selection of oral and injectable agents to treat patients with diabetes. Glycemic control is important. It's the bread and butter of treatment of diabetes. The benefits cannot be stressed enough of proper glycemic control. There's a reason we have these targets that we stick to. Compliance is an issue with a lot of patients, the quality of life. This influences their choice of drug. Do they want an injectable? Do they want an oral drug? How easy is it to take? More than once a day, once a day? And these are really, to be honest, factors that would influence the patient's compliance and the outcome in a real-world setting. So gliclazide is, in my opinion, still an effective oral hypoglycemic agent. It can be safely utilized in our choice of medications for treatment of diabetes. And the good part about this is it has its own unique way of working, different from DPP-4s, different from SGLT2 inhibitors. So actually, there's no harm in combining several of these agents in your patient if you really needed to do so. And thank you.
Thank you very much, Dr. Mariam. I think we have one question, and we have a window just for one or two. There is a question which is asking about whether we can combine sulfonylurea and glinides as long and short insulin sensitizer in patients who are poor and young, like Remicron MR and ribiglanides. I'm not sure if you have any coming across this idea before.
It's an interesting question. I've definitely seen patients who are on such a combination. I wouldn't prescribe this combination myself, to be honest. Glinides in general, the efficacy that we see is quite low compared to the other agents available, especially with sulfonylureas. I would say the situations where I would encounter this, I may have in some cases continued the treatment and not changed it, would have been in older individuals who are completely resistant to any type of injectable treatment, who were started on these agents years ago, many years ago, when there were no other oral agents available, who may have other contraindications to taking newer agents such as SGLT2 inhibitors, maybe because of recurrent UTI, maybe because of other risk factors that they have, which makes them not suitable to get newer agents. But in general, it's not a combination that I would go for. However, I'm not aware of a study that looked into this or anything in the guidelines.
Thank you. There is another question, which will be the last. What about combination of a gliclazide MR and GLP-1 agonist? And so if you start the patient in both, or you just add GLP-1 on top of gliclazide, do you need to reduce the gliclazide dose?
Now, there is no, you can combine both, okay, if you needed to. However, reducing the sulfonylurea dose or gliclazide dose whenever you start another agent really depends on what the glycemic control was to begin with. If you had someone who was fairly well controlled or is at risk of hypoglycemia, you may want to be careful and reduce the dose. But in someone who has very high sugar readings, that wouldn't be much of a concern. GLP-1 agonists in general do not cause hypoglycemia unless they were combined with sulfonylurea or insulin. That would increase their risk, obviously. They can lead to some degree of hypoglycemia, but not to the extent that you would see with the sulfonylureas and with insulin. So I would be cautious, but really to answer that, I would say it depends on whether you'd reduce the dose, depends on your patient's background, Do they have chronic kidney disease? Do they have, hypo unawareness? Did they have hypos in the past? So really, as we know, the guidelines go, all our treatment is personalized now. There is no one size fits all.
Excellent. Sounds good. Thank you. Thank you, Dr. Mariam.
Thank you.
Thank you for your presentation and answering the questions. And now we reach the end of our symposium for today. Thanks for all the attendees. And we just would like to remind you that this activity is accredited by 1.5 CME hours from Dubai Health Authority. And CME will be available in 14 days. But you need to fill out the evaluation form that will be sent to your registered email ID in order to obtain the credits. Also, would like to remind you that this webinar and the previous webinars are available on demand on EDS YouTube channel and EDS Institute websites, so you can view it anytime you wish. We encourage all of you also to participate in our future activities that are held by the Emirates Diabetes Endocrine Society, which will be EDS Connect Diabetes Endocrine Thyroid. And for the first time, collaboration between the EDS Society and the International Society of Endocrinology. There will be a Practice Middle East Congress on 17 and 18 of September. And the third edition of this year Young Leader Forum will be held on 13 of October. We encourage you all to participate and to register for the upcoming event. Thank you very much, and wish to see you in coming events, inshallah.